Hello, and welcome to the Chest Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Gretchen Winter.
On behalf of Chest, I would like to welcome you to this Chest Journal podcast. My name is Dr. Gretchen Winter, and I am your Chest podcast moderator. So thank you all for joining us today for a discussion with Valerie Dehondt and Lies Lahousse. They and their colleagues wrote an article in the Chest Journal, Exacerbation Risk by Chronic Proton Pump Inhibitor Use in Obstructive Lung Diseases, which I will now be calling proton pump inhibitors a PPI for the rest of this podcast. So Valerie Dehondt is a pharmacist and currently a PhD researcher in pharmacoepidemiology at Ghent University in Belgium under the supervision of Professor Lies Lahousse. Her research focuses on the impact of nutrition and medication on lung health in the general population and in patients with chronic obstructive airways diseases specifically, also including factors associated with underdiagnosis of COPD. And Dr. Lahousse is a pharmacist and epidemiologist with a doctoral degree in medical sciences. She is professor at the Faculty of Pharmaceutical Sciences at Ghent University in Belgium and PI pharmacoepidemiology within the Erasmus Medical Center in Rotterdam, the Netherlands. She leads population research focused on precision medicine, including optimizing the benefit-risk ratio of approved drugs by studying heterogeneity among phenotypes, endotypes, and underlying genetics, with the ultimate goal of improving care of patients with chronic complex diseases such as asthma or COPD. So thank you so much for joining us, to both of you all.
Thank you. We're happy to be here.
Thank you for the kind introduction.
Absolutely. So let's go ahead and dive in. Now, y'all looked at whether chronic PPI use was associated with exacerbation risk in obstructive lung diseases. So we all know that we have many different patients with asthma and COPD who are on PPIs. So why did you ask this question? What prompted you to specifically research this question?
So proton pump inhibitors, or PPIs, are among the most widely prescribed medications worldwide, and they are often used on a long-term basis. Since their introduction in clinical practice, PPI use has increased dramatically, and in recent years, there has been growing concerns about the potential inappropriate prescribing and the long-term safety of these drugs. The fact that PPIs were also the most common co-drug in Belgian patients with obstructive airway diseases prompted us to research this further. PPIs are moreover associated with substantial costs for both patients and governments, and they have a potential risk of adverse events or drug-drug interactions in patients with polypharmacy.
So what did we know from the literature before this study about the use of PPIs in obstructive lung disease?
Well, PPIs are indeed recommended as a first-line pharmacological treatment for GERD, and we know that GERD is a common comorbidity in patients with chronic obstructive airway diseases. It has been associated with worse symptoms and higher risk of exacerbations in these patients. So actually, we thought and hypothesized that treating GERD with PPIs might help reduce the exacerbation risk. However, the previous studies were rather inconsistent regarding the use of PPIs and the risk of exacerbations.
So can you please give us a brief overview of your study design?
Within a nationwide observational cohort of chronic inhaler users between January 2017 and December 2021, we followed PPI users until their first moderate or severe exacerbation during follow-up and compared them with patients not using PPIs. We excluded patients with contraindications to PPIs or those using histamine 2 receptor antagonists. To assess a potential dose-response relationship, we calculated the cumulative PPI use over the previous year using defined daily doses and grouped patients into 4 increasing categories of cumulative exposure.
Interesting. So were there certain characteristics that you noted in PPI users versus non-users?
Indeed, definitely. We included almost 1 million patients, and almost half of them were using PPIs. And compared to non-users, PPI users were more often female, older, they had a low socioeconomic status. They were also more likely to have a history of smoking, more baseline exacerbations, and a higher burden of comorbidities, such as cardiovascular disease. Therefore, we adjusted all analyses for age, sex, smoking history, socioeconomic status, and the exacerbation history, but also the short-acting bronchodilator use, being more frail, the comorbidities, and of course also having GERD.
Well, excellent. And what did you find about the association between chronic PPI use and exacerbations?
In our weighted Cox regression analysis, PPI use was associated with a 16% higher risk of exacerbations in patients with obstructive lung diseases. We also observed a clear dose-response pattern. Compared with non-users, the risk of exacerbations increased from about 9% in patients with low cumulative exposure to about 24% in daily users. Interestingly, PPI users who were also taking a CYP2C19 inhibitor, mainly fluoxetine or fluconazole, and which were therefore theoretically increased their PPI plasma concentrations, showed an additional 17% increased exacerbation risk compared with PPI users not using such an inhibitor.
Fascinating. So, what are possible explanations for that finding?
Well, several hypotheses have been proposed to explain why PPI use might be associated with an increased exacerbation risk. First, PPIs can alter the gut microbiome. They may cause overgrowth of pathogenic bacteria, leading to gut dysbiosis. This microbial imbalance has been associated with increased systemic and airway inflammation, and it may influence lung immunity. Additionally, dysbiosis in the gut may influence respiratory microbiota through translocation of gut microbiota to the lungs and through altered circulating inflammatory cytokines, leading to lung dysbiosis, which may affect lung function negatively. And then secondly, there's also a hypothesis about direct cellular damage, where the blocking of lysosomal proton pumps may lead to an accumulation of protein aggregates, and this is associated with oxidative stress, endothelial dysfunction, and also accelerated endothelial aging. And these changes may increase vascular permeability and thereby contribute to poorer disease control. And then, of course, third, we also know that PPIs raise gastric pH, and this interferes with the activation of pepsin. And when proteins are not fully digested, they may act as antigens and could trigger immune responses such as T helper 2 response or IgE sensitization. And this might trigger actually asthma exacerbations. And then, of course, finally, PPIs are also associated with vitamin and mineral deficiencies, and this may contribute further to an increased exacerbation risk.
And can you please share some of the limitations of your study?
A first limitation was that PPI use was based on dispensing data rather than actual intake, which could lead to overestimation. At the same time, PPI use may also have been underestimated because small over-the-counter packages of low-dose PPIs are available in Belgium without reimbursement, and these are not captured in a national database. Because of the observational study design, coding errors and misclassification bias are possible. Certain factors such as obesity or being overweight or smoking may also be underreported. However, we addressed this limitation by using broad definitions that incorporated ICD codes, medical procedure codes, and medication use. A second limitation was that information on disease severity was lacking. We mitigated this limitation by using proxies for disease severity, such as exacerbation history and short-acting bronchodilator use, which indeed seemed to modify this association partly. Third, despite an adjustment for many confounders using stabilized inverse probability of treatment weighting, residual confounding by unmeasured factors cannot be excluded fully. For example, if smoking was not registered, it may still have influenced results because smoking is linked to increased gastric acid production and reflux. And lastly, our findings are limited to patients treated for obstructive lung diseases and cannot be generalized to those not receiving respiratory medication.
And so what unique findings does your study add to the literature? Like, what do we know now that we didn't before this study?
Well, it added that especially long-term PPI use may be harmful to patients with asthma or COPD. Importantly, we observed that short-term PPI use in patients with GERD was not associated with an increased exacerbation risk. And this is clinically relevant because PPIs remain the first-line pharmacological therapy for GERD.
Absolutely. So based on your findings, then, how does this affect clinical care? Like, how would you recommend changing clinical practice, especially for patients with concurrent GERD and obstructive lung diseases?
Our findings mainly underscore the importance of thoughtful prescribing of PPIs in clinical practice, especially in patients with obstructive lung diseases. PPIs are often prescribed inappropriately and are continued chronically without reassessing whether there is still a valid indication. In our study, short-term PPI use in patients with GERD was not significantly associated with increased exacerbation risk, whereas long-term use, even in patients with GERD, was associated with a higher risk. This highlights the need to carefully evaluate whether PPI therapy is truly necessary and to avoid unnecessary long-term treatments.
And what do you see as future steps for this research?
Well, we think we definitely need to better understand how PPIs might influence respiratory health, for example, through these microbial pathways. PPIs are known to induce gut dysbiosis, and disturbances in the gut microbiota may in turn affect lung immunity and the respiratory microbiome. This fits within the broader concept of the gut-lung axis, which has been increasingly recognized as relevant in respiratory diseases. However, much of the mechanistic evidence is still limited, and laboratory-based studies are needed to unravel how these microbial and immunological pathways interact.
Well, this is just fascinating. And if you could give our listeners a closing thought on what you've learned from this research, what do you want them to take away from this discussion?
One key takeaway from this research is to be mindful when prescribing PPIs in patients with chronic obstructive airway diseases, especially when there is no clear ongoing indication. For patients already taking PPIs, it is important to regularly reassess the need for continued treatments and to deprescribe whenever possible. Thoughtful and appropriate use of PPIs can help minimize unnecessary risk in this vulnerable population.
Well, a very big thank you to both you guys, to Dr. Dehondt and Lahousse, for a really great conversation on a very interesting topic with some unexpected results. And a big thank you, of course, to our CHEST community for joining us as always. I'm Gretchen Winter, and this is a CHEST podcast. Until next time.